time in terms of burden of surveillance. We have our brilliant chair of the I committee, Professor Cassius Pawlak, and yeah, the floor is yours.
Thank you so much for this very nice introduction, and thank you so much for having me. A big kudos to my two favorite professors. I would say that three favorite professors, because also the president of the society, for having me. And I will try to answer the question, which is if the high quality screening colonoscopy can decrease the need for subsequent surveillance, because we do a lot of surveillance, of course. But we have to first indicate why this matters. So we know still that in the global cancer incidence, the colorectal cancer is accounting 10%, so it's still at the third place in global cancer incidence. And in 2020, despite we perform a lot of things to improve it, we still had 2 million new cases and 1 million deaths yearly. But what is also reported by International Agency for Research on Cancer, by 2040 we will have a global burden of colorectal cancer, so this will increase by 56%, so we will have 3 million new cases a year. So that's why we perform a prevention for it, as this is a pathophysiological rationale standing behind it. We have this adenoma-carcinoma sequence, which typically takes around 7 to 10 years till the carcinoma will develop from adenomas. So that's why we screen patients and we try to detect and remove all adenomas before the malignant transformation will appear. So by this, we lower the CRC incidence, but we can of course lower it when we will perform a high quality colonoscopy. But what really means a high-quality colonoscopy? As Cesare was mentioning before, we have all these key performance measures we're supposed to take a look on them. So there are some pre-procedural ones, so how the patient will be adequately prepared for colonoscopy. Then if the colonoscopy will be properly performed, so namely the cecal intubation rate will be more than 90%. Of course, if we will detect adenomas in more than 25%. So these are our very important key performance measures, but also we have to remove them properly, and then of course we have to do something with them after. But aside of that, we have to take a look at the rate of complications and patient experience, because if the patient will have a maybe bad experience or maybe complication will appear, it's a question if patient will come for surveillance after it. And the concept, of course, for those guidelines is that the higher quality of colonoscopy will be performed, the lower miss rate of adenomas and lower the risk of interval cancer will appear. So there is the question if we can change something, if we will perform a high quality colonoscopy, the index colonoscopy. So if we can safely extend or even defer the colonoscopy without increasing CRC risk. And there is an evidence behind, which is linking colonoscopy quality to the outcomes. And you can see that we have a lot of studies published since 2006, which are indicating that actually based on those quality metrics, we can prolong interval for doing subsequent surveillance. And this is very important. But then, of course, it's all about what we have after. So what will be the type of the polyp removed, what will be the size, the number of polyps, and type of dysplasia. Because we have, of course, some guidelines like ESGE guidelines, which are a little bit complex and having different periods of surveillance for too many data, I would say, and too many different indicators indicating when the surveillance is supposed to be performed. But we have, of course, our ESGE data and ESGE guidelines, which are a little bit simpler and indicating very straightforward surveillance for it. So actually our guidelines lowering the need for surveillance and frequency for surveillance. It's, of course, we perform surveillance, but still we feel it's a lot. Because surveillance accounts 40% of all colonoscopies. And then, of course, when it comes to the total workload, the incorrect surveillance accounts 1/3 of all performed colonoscopies. So still, we, of course, care about the patients. We care about the further presence of the interval cancer, but we perform maybe a little bit too much. So that's the question. And there are some downsides coming from it, from unnecessary follow-ups, because we can increase by this procedural risk for bleeding and perforation. So when this probably happened to patient, we are not sure if the patient will come back to us. Then of course, if we screen and perform more and more, then the patients started having questions why we screen so much, why we perform that. So patients feel anxiety and there's a patient's burden. And of course, we impact the healthcare costs and the resource strain. So we have limiting access for initial screenings, and we have, of course, limiting access for any other important procedures because we have to shift our resources. So we have to be balanced in CRC prevention. I feel we have to optimize the colonoscopy services in terms of course, index colonoscopy and then further surveillance without harming the patients. But of course, we have to determine who will benefit the most from surveillance and what would be appropriate time frame between subsequent colonoscopies for those patients, of course. And there are some potential benefits coming from it. Of course, fewer procedures, lower rate of complications, fewer procedures, resource optimization, so we have to plan it for our daily work, and of course, we can just shift our resources for any other procedures. Of course, by this, we will reduce healthcare costs, and we will, of course, cause less patients' anxiety and inconvenience. And I just want to enclose you quite recent study which showed what is the evidence behind the surveillance actually performed. And the study is coming from a national cohort of the English patients from bowel cancer screening program. They did a great job because they included 44,151 individuals who underwent in total 64,544 surveillance episodes, so quite a lot of checkup. And they divided patients into two groups, so high risk and low risk and intermediate risk. And they see the first surveillance that actually advanced adenoma was presented in 10% of all of those patients, and CRC appeared in 0.5% in entire cohort actually. But when they divided them into high risk group and intermediate risk group, the evidence was a little bit showing up that the advanced adenoma yield was a little bit higher for high risk, but when it comes to CRC presence at the screening one was actually similar in both groups, so no big difference between high risk group and intermediate risk group. And finally, the outcomes showed that actually the adenoma and CRC rate at surveillance was quite low. And probably there is coming from it the information that whenever high-quality index colonoscopy is performed with a good follow-up surveillance, but not many surveillance, but one surveillance, we can decrease the rate of missed and metachronous colorectal cancer. So maybe we could change our guidelines further based on it, not only the one study, but of course we need more data, but still maybe those patients who had a single adenoma, so the adenoma greater than 10 millimeter in size, and these account 6% of all adenomas at follow-up, that was 1/3 of all surveillance cases, so maybe we should not need to surveillance those patients or by this reduce the workload. So the general conclusion coming from the study was that actually because the rate of incidence was low for advanced adenoma and CRC during the surveillance in comparison to the general population, maybe we should even change the further surveillance for this group of patients. However, there are some practical considerations coming from it because I know that we struggle with this so much also in my country. I'm from Poland, so we don't have systems for monitoring the endoscopist level of quality. And the colonoscopy quality metrics, we cannot report them so much. In terms of ADR prep, of course, it's possible, but we still don't have in total the tool which could show us if we perform a high-quality index colonoscopy or not. Of course, we have to take into consideration optimizing the split dose prep because patients still don't do a good job. We have also high-definition imaging by using AI and any other high-quality scopes, so we can improve it in performing high-quality colonoscopy, as Cesare was mentioning it. But of course, we struggle with a clear documentation for quality indicators during initial colonoscopy, so probably these are some practical considerations which should be implemented in the future to improve, again, high-quality colonoscopy index and surveillance one. But still we have some limitations and controversies, as we know that detection of sessile serrated lesions, which can carry also the risk of developing dysplasia and further cancer, still these lesions can be measured in the colonoscopy, so it's very hard sometimes to detect them. But also we have some patient factors, independent factors that still mandate shorter surveillance, so we still have those group of patients we have to screen and surveil. And of course, we don't have long-term data more than 10 years, which show us that really we can prolong surveillance or even refuse surveillance for a particular group of patients. And finally, we don't know what's the ADR thresholds across the populations because we don't have a good tool to monitor it. So in summary, there is some things to talk about. Of course, the high-quality screening colonoscopy, we believe that reduced rate of missed lesions and interval cancers, because you can see that from our data. We have some, of course, evidence supporting like lengthening surveillance intervals when the initial exam is really, really good. But of course, the emphasis should be put towards improving colonoscopy quality rather than increasing frequency. So we have to really be conscious about that we have to do a good job just to then further protect, I would say, patients for unnecessary surveillance. But of course, we have to take a look at the future guidelines. If even, despite we have a very good ESG guidelines show intervals, maybe we can cut them even more. But before I will finish, I strongly, of course, indicate and encourage you to join and to follow activities for young endoscopists. So I would say people below 40. And then there is a lot of them because we have ESGE endoscopy camp, which was done recently in September. That was a high success. Like young endoscopists were very happy with it because it's very good practical course helping to advance in procedures. Of course, we have ESGE Academy. There is a resource, online learning platforms. You can find everything there to upskill yourself in particular procedures. We have many supportive awards, like a Next Generation Award for future generations in endoscopy. We, of course, have fellowships and grants and mentorship program when you can get into closer contact with your mentor and really benefit from it in many levels, like, of course, writing papers, but also performing procedures, but also your maybe work-life balance and so on. So strongly encourage you. You can follow the ESGE website by scanning QR code, but also, as Cesare mentioned, that we have many other different things, like, for example, a research camp, and the deadline is coming soon, so please scan it and apply for it. It's also good benefit to get into contact with top editors and also top researchers and take some advantage from them. And aside of that, of course, submit your abstract ASAP. This is the QR code for just direct submission of your abstract, and we are waiting for those because this is shaping our program, and you can also get some recognition and also some benefits and travel grants, so we are looking for it. So thank you so much for your attention.
Thanks, Cassia. Very nice presentation. I have a quick question, a quick answer. The main problem in my activity is that despite I recommend very long-term surveillance, patients, they come back very soon with a lot of anxiety, even for a 3 millimeter low-risk adenoma. Oh no, I don't believe it is a low-risk adenoma. Even for hyperplastic polyp, oh no, I want to have a colonoscopy again. So how can we convince patients that maybe too much surveillance is really not needed?
I personally feel that we miss time because, like, we don't have time really for the discussion with patients, and what we do, we just sign up and write. Like screening, like surveillance in 6 months, surveillance in 1 year, in 3 years, and so on. So we don't have really time for talking to patients and convincing them that this is really low risk of having anything in the future. So I think that's the main pitfall, that we are too busy to have a time to really sit with the patient after and convince that the rate of further interval cancers and adenomas is really something important.
Yeah, I think this is very important. At least we do for advanced procedure in our institution, but probably we should do for any procedure in any hospital. Okay, thanks, Cassius.
Thank you.